Good morning. Welcome to our attendees who have joined us today and those joining via the recording to the North Simcoe Muskoka Specialized Geriatric Services practice short for September 2025. My name is Jackie Saul, and I'm one of the psychogeriatric resource consultants with NSM SGS. We're going to start this morning with a land acknowledgement. We're gathering this morning on traditional lands sacred to many Indigenous nations. I would like to acknowledge the traditional territory of the Anishinaabeg, which includes the Odawa, Ojibwe, and Potawatomi nations, collectively known as the Three Fires Confederacy, the Haudenosaunee and the Wendat nations, and the presence of other First Nations, Métis, and Inuit residing in the Simcoe Muskoka territory. Most of us have come here as settlers, immigrants, or newcomers in this generation or generations past. We are all treaty people. As such, we commit to collaborating based on the foundational assumption that Indigenous peoples have the power, strength, and competency to develop culturally specific strategies for their communities. We're dedicated to honoring Indigenous self-determination, history, and culture, and are committed to moving forward in the spirit of reconciliation and respect with all First Nation, Métis, and Inuit people. This morning's session is being recorded and will be accessible on the SGS website. If you're watching the recording, welcome. And just a reminder that if you'd like to join us live, the practice short sessions are offered on the second Friday of each month at 8:30 in the morning. I am pleased to introduce today's presenter, Allison Jayawira. Allison is a registered nurse working as a PRC with NSM SGS. Allison co-chairs the BSO Knowledge to Practice Community of Practice and the BSO Schizophrenia Capacity Building Working Group. Allison is an excellent colleague and advocate for older adults. I'm very pleased to introduce her this morning. Welcome, Allison.
Thank you, Jackie. Thanks to everyone on the call as well for taking the time out of your busy day to join. We're going to be spending the next 20 or 30 minutes together, and this slide deck that has been pulled together from the BSO Brain Exchange website, and the link for which is going to be made available towards the end of my talk. The slide deck plus many other resources are available on this site. It's not password protected either. It's for your use. So I will encourage you at that time to get at her and download things. My goal is for everyone to leave with a few added skills and increased knowledge and confidence in using the Behaviour Supports Ontario Dementia Observation System, which is also known as the BSO-DOS. The BSO-DOS is a standardized version of the Dementia Observation System. It was created in 2019 and has now been updated in 2025, which is the one that I'm going to be discussing. Throughout our region, we hear of the interest in getting rolling with version 2 of the BSO-DOS, and we're kind of considering this a bit of a soft launch for this new version. The changes made from the version from 2019 were done so with feedback from teams across Ontario, including teams in North Simcoe Muskoka, and are reflected in the version 2. Reliable, direct observation tool provides objective data about a person's behavior every 30 minutes for 24 hours over 5 consecutive days. The information gathered over these 5 days is extremely valuable in understanding the meaning of behavior and to find individualized care approaches to reduce or eliminate responsive behaviors. The BSO-DOS is considered an essential tool in your best practice toolkit for behavioral assessment and individualized care planning for persons living with dementia. So the BSO-DOS is used to identify behavioral patterns, trends, contributing factors associated with responsive behaviors or personal expressions of risk. It's used to develop tailored non-pharmacological approaches to address some of those unmet needs. It's used to evaluate the outcomes of non-pharmacological approaches, and it's also ideal in measuring the impact of medications. For example, if Tylenol is added to see if there's any behavioral changes. A BSO-DOS should be completed when there's a need to understand and identify behavioral patterns, frequency, duration, and level of risk. This includes when there's a change in behavior, a medication adjustment, as I just alluded to, or to evaluate the outcome of a new strategy or approach. It's also beneficial to use around transitions of care. For example, when someone moves from community to acute care or acute care to long-term care or any other transition consideration, we know that even moving a person from one room in long-term care to another room in long-term care can contribute to personal expressions, and so a BSO-DOS may be recommended. In North Simcoe Muskoka, we're fortunate to have behavioral supports in long-term care, in community, and acute care. When we're all using the same tools and documents, communication and wraparound care become more streamlined and, more importantly, person-centered and relationship-centered. So we're going to launch a poll here, and I want to get a little bit of an idea of your experience in using the tool. So how familiar are you with the BSO-DOS? This is the first time hearing about it. I've heard about it, but I've never used it. You use it occasionally. I use it all the time. I use it often. I'll wait one momento.
Alison, can you see
Okay,
the results of the poll?
I can. Is it okay if I end the poll?
Absolutely.
All right, sorry everybody, I can see there's a few people that might want to get in there, but I'm gonna end it now because we've got about 90% highlighted, and I'll just share the results here. Hoping you can see this. There are folks on here that have got a lot of experience. I'm really thrilled to see that there's folks that haven't got as much experience because I think this might be quite beneficial. So there's 4% of you, this is the first time you're hearing about it. 17% of it, you've heard about it but never used it. 25% of you have used it occasionally. And then there is a good size group that uses it often. And so I am thrilled to see this makeup of folks. So this kind of segues nicely into the talk. So for those of you who've used the BSO-DOS, I'm curious about the parts of the tool that you have completed. And I encourage you to just type into the chat box for the whole group to see, around what parts of the tool you've completed. The background section, data collection table, the analysis and planning section. And then I'll add a fourth one to say, yeah, I've done it all. So I encourage you to put that in there if you so desire. I'm going to ask a couple of extra times throughout the talk for a little bit of chat box stuff just to support some of the learning here too. So whatever your role is that you've played in completing, so thank you. Everyone's role is valuable and needed in ensuring that it's clinically valuable. This is truly a tool that relies on teamwork to ensure that proper information is recorded and communicated in a timely manner. Again, I'm going to encourage you to use the chat box. Feel free to type into the chat box the different benefits that you've seen in using the BSO-DOS. As I said, with 54% of the group on the call, with quite a level of knowledge, I really want to hear from you to help kind of cross-pollinate some of the learning. What are some benefits that you've seen in using the tool? And also, I'm curious too about if there's anything about the person that you've learned about the person using the tool that's informed then successful care strategies. Feel free to type in. And for those of you watching the chat box, have a look. And I hope that there's some learning that occurs there too. So we're going to watch a little video. This kind of reviews the details of how to complete the tool. The video is about 6 minutes. I toyed with not playing it, but it is really quite valuable. And so what I'm going to do is turn off. No, I'm just going to share the video.
Welcome to this video on the Behavioral Supports Ontario Dementia Observation System, or the BSO-DOS. Thank you for your dedication to providing.
Sorry, everybody. I'm having a few issues here.
Welcome to this video on the Behavioral Supports Ontario Dementia Observation System, or the BSO-DOS. Thank you for your dedication to providing person-centered quality care for people living with dementia. You are a valued part of the team, and your role in completing the BSO-DOS is essential. Let's start by reviewing the purpose of this clinical tool. The BSO-DOS is a direct observation tool. This means team members record in real time what they observe about a person's behavior every 30 minutes for 5 days in a row. This approach gathers objective, measurable information. The data collected helps the team to find patterns, trends, and contributing factors of responsive behaviors and personal expressions. This is essential in finding strategies that address unmet needs and ultimately reduce or prevent behaviors. The data collected can guide non-pharmacological approaches, such as new communication strategies, promoting meaningful engagement, or adapting the environment. The BSO-DOS can also help measure the impact of medications. The BSO-DOS involves 3 steps. Step 1 is the background section. Step 2 is the completion of the data collection sheet. And Step 3 involves analysis and planning. Let's walk through each step in detail. Step 1. The background section is completed by a team member who initiates the BSO-DOS. This might be a nurse or an allied health professional. They check the reason for completing the BSO-DOS, like a recent move or a new behavior. They note the start and end date of the observation period, and they add their name and signature. This section ensures the whole team knows why the BSO-DOS is being completed and how long it will last. Step 2 involves completion of the data collection sheet found on page 2. Point-of-care team members, such as personal support workers, nurses, and allied health professionals, fill out the data collection sheet over the 5-day observation period. Every 30 minutes, they record the person's behavior, including sleep patterns, positive engagement, and any responsive behaviors. They use number codes from the observed behavior legend. For example, if Miss Chang is yelling, "Help, help," and banging on the table at 10:30, they write numbers 4 and 5, the codes for vocal and motor expressions, in the 10:30 block. In the observed behavior legend, specific behaviors are listed under each category. Team members check off the specific behaviors as they are observed. In this example, repetitive words and banging are checked off within the vocal and motor expressions category. This tracks the specific behaviors expressed, assisting teams in assessing risk, as well as identifying contributing factors and planning tailored approaches. On the data collection sheet, team members can also add context using letters from the context legend. This isn't required, but provides valuable information in identifying contributing factors. For instance, if Miss Chang was alone when yelling and banging, the letter A can be added in the context column at 10:30. To meet documentation standards, team members who contribute to the data collection sheet add their name and initials to the data collection table contributors section. At the end of the 5-day observation period, the team will have completed the data collection sheet. Next is Step 3. This is where the data collected by the BSO-DOS is reviewed and analyzed, and its valuable information informs next steps. First, the numbers on the data collection sheet are highlighted according to the colors in the observed behaviors legend. Next, a team member whose scope of practice involves assessment and analysis, such as a nurse or allied health professional, completes the calculations in the analysis table. They start by counting the number of half-hour blocks where behaviors of interest are recorded each day. Not all behaviors need to be counted, but in addition to the behaviors of interest, it is helpful to know how much the person is sleeping and positively engaged. Then they add up all the number of half-hour blocks in each row across all 5 days. The next step is calculating the average number of 1-hour blocks the behaviors of interest occurred per day. This is done by simply moving the decimal point 1 space to the left. For example, if vocal expressions occurred in 27 blocks over the 5 days, it happened on average during 2.7 1-hour blocks each day. Now the team member reviews the completed analysis table and the highlighted data collection sheet to decide if any behaviors are a concern based on their frequency, duration, and the level of risk. They note these concerns by checking off the boxes on the right of the analysis table. This helps to determine which behaviors need to be prioritized in terms of planning ways to prevent or reduce them. The final part of Step 3 involves documenting a progress note regarding the outcome of the BSO-DOS in the clinical record. This should include a summary of the completed analysis table, details about the BSO-DOS data revealed, any identified causes and contributing factors of responsive behaviors, and the next steps. Let's recap the importance of everyone's contribution to the BSO-DOS. The BSO-DOS is an essential tool for behavioral assessment and individualized care planning. When responsive behaviors or personal expressions occur, using the BSO-DOS helps teams understand the behaviors and identify unmet needs, leading to individualized approaches to care. Different team members complete different parts of the BSO-DOS, yet each contribution is essential. Fulsome, accurate data collection allows for meaningful analysis and tailored approaches that address unmet needs. Thank you for the role that you play in completing the BSO-DOS. To learn more, you can find several resources about the tool on the BSO-DOS website. This is also where you can download the BSO-DOS. For additional questions, reach out to the BSO Provincial Coordinating Office. Thanks for watching.
Okay, welcome back. Apologies for it being very small. Hopefully that only encourages you to go to the BSO Brain Exchange website to have a look at it yourself. Best laid plans, right? So I know the chat box is quite busy, and I'm hopeful that if I need to know anything, Jackie and Brittany, please let me know. And so I'm going to push us along, though, in the interest of time as well. And so now that we've met Mrs. Cheng in the video, we're going to learn more about her and have a bit more time to find out how the data collected in that BSO-DOS informed then person-centered strategies to help reduce her personal expressions of risk. So Mrs. Cheng is an 86-year-old woman who's recently moved from her daughter's home to a long-term care home. She has a diagnosis of mixed dementia and now requires a wheelchair. She can no longer walk. She's able to engage in simple conversation, mostly using 1 or 2 words. Through collecting personhood information, the team learns that she has a large family, and her home was often the central meeting place. She loved to cook, and her specialty was homemade dumplings. The team noticed that there are many times in the day when Mrs. Cheng calls out, yelling for help, and when they go to assist her, they struggle to figure out what in fact she needs. The team decides to complete a BSO-DOS to better understand the timing, context, and any patterns around these times. The first step, as was highlighted, is to complete the step 1, the background section. As she's just moved into long-term care, the team checks off baseline admission. And since the family reported that she's not been calling out at home, they've also checked off new behavior and noted that calling out was in fact the specific behavior in question. Then for 5 days, the clinical team completes the data collection sheet. This involves the contributions from several point of care team members, including personal support workers, nurses, allied health professionals, who ensure that observations are recorded every 30 minutes. This is a significant time commitment. But this information is key to understanding Mrs. Cheng and finding out the approaches and strategies to decrease her distress. In order to get an accurate depiction of the frequency, duration, and risk of the behavior, it's important to have the data collection sheet completed. After the 5-day observation period, the team members highlight the data accordingly to the color-coded legend. This is where you can get out your multiple highlighters and have a little bit of fun. The reason for the color coding is to better see the trends in the person's day. So it kind of pops out at you when you see the trends of colors. From this data collection sheet, we can see that Mrs. Cheng has repetitive, I'm going to go back 1 slide. Repetitive verbalizations. Hang on a second. Typically that occurs when she's alone or in loud environments or during personal care. And then at times Mrs. Cheng's vocal expressions escalate into verbal and physical expressions of risk. Generally, Mrs. Cheng sleeps well at night, with 1 night of disrupted sleep. We can also see from the data collection tool that Mrs. Cheng has very little positive engagement throughout the day, which I'm going to highlight more. You can see it more easily in a future slide. And so that's the data collection sheet. And from there, then, a designated team member calculates the quantitative data using the analysis table. This is done by adding up the number of each occurrence on each day and putting it in the table. So you can see it right there. Then tallying up all the half-hour blocks over the 5-day period. So for example, when we consider the top line sleeping, Mrs. Cheng has a total of 101 half-hour blocks of sleeping. And to calculate the average daily hours per line, you divide by 10, which is highlighted here. So as I'd highlighted previously, Mrs. Cheng's time spent positively engaged is quite low. It's only on average about 1.3 hours per day. And the vocal expressions are the most common responsive behavior, considering both frequency and duration. And so that's what this analysis and planning table highlights. And a really key piece of that data collection sheet is to then move to the analysis and planning. So based on the information, the team determines that the BSO-DOS reveals that Mrs. Cheng's repetitive vocal expressions typically occur when she's alone, especially in the morning when she gets out of bed and after meal times when residents are leaving the dining room. Mrs. Cheng expresses distress through repetitive vocal and motor expressions. When she has poor sleep the night before, the vocal expressions are more likely to escalate into expressions of risk. The more Mrs. Cheng is positively engaged, the less she expresses responsive behaviors. And as I had highlighted, on average, Mrs. Cheng was only positively engaged 1.3 hours a day. In collaboration with the family, the team identifies the following possible causes and contributing factors. It's stressful for Mrs. Cheng to be alone. Her family reminds the team that Mrs. Cheng is used to others being around her. Mrs. Cheng sleeps better when she has pain medication at bedtime. And this wasn't given the night before she slept poorly. And Mrs. Cheng needs more time engaged in activities that are meaningful. And so then in collaboration again with the family, the team made the following plans based on what was identified through the BSO-DOS. Pain medication is going to be administered as a scheduled dose in the evening rather than PRN to alleviate pain and promote restful sleep. Pain will be assessed each shift. We did identify that we were going to get her engaged in positive activities, which then leads to a progress note. And I just need to move this around. There we go. And this is an example of the progress note. It is available on the Brain Exchange website for you to look a little more closely at, but it basically runs down the analysis of what was learned through that BSO-DOS and the planned next steps for the team. Again, we know there's lots of benefits of the BSO-DOS, but we're also aware that there are some challenges in completing the tool. And so, again, in the chat box, for those of you with lots of experience, what are the challenges your team, or anybody, what are the challenges your team face in using the DOS, the BSO-DOS? How might you overcome these challenges? And what are some next steps, in terms of using the BSO-DOS in a more effective and valuable way? We know that some of the challenges are logistical in nature. Filling it out consistently. Yep. Staff engagement. I know. I see that. Yes. Filling it out properly and consistently. Absolutely. Some of the challenges are logistics. So not having access to highlighters. And I know that might sound silly, but yours truly really is quite a visual person and it does help to see that. And then human resources, as you're saying, it is challenging to fill it out every 30 minutes. I've worked with groups, and problem solved through this, and some of the suggestions have come up to make sure that we talk about it in before our shift, who's on DOS, who isn't on DOS, maybe even a communication board if that works. And then also every 30 minutes is very challenging, unless of course you're a supplementary staffing person, at which this is an ideal document. So the suggested successful completion of the DOS is to do it at your first break, meal break, second break, end of shift, so that you're not leaving it all to the end or not doing it all together as well. And then similar permutations can be useful as well. Okay, so I hear about the electronic and the tablet piece too. When working with community, it's possible as well during your shift. Yes, Magdalena, the slides are all on the Brain Exchange website, which beautifully segues, I think, into my next slide. You can access every single thing off of this the BSO Brain Exchange website the fact sheet, the user guide, the resource manual, that video that I showed that was teeny tiny. And so, yes, please use them. All of them are available. They're plug and play. They even have speaker notes if you so desire. I'm also mindful, as somebody highlighted, that some of you may be interested in building this into an electronic documentation system, as there are various electronic documentation platforms used across Canada, as well as within and across sectors. We know this in North Simcoe, Muskoka. The Behavioral Support Provincial Coordinating Office will work directly with your organization to build the BSO-DOS into your electronic medical systems. Any such build is guided by the electronic BSO-DOS standards to ensure that standardization of the tool. And they welcome you to reach out. The website is noted here, as well as a little tiny QR code. And so as I wrap up, I want to say a massive thank you for, first of all, coming here today, but also for the work that you're doing and your commitment to those you care for. And for those who are contributing to completing BSO-DOS or wanting to learn more about it. I do hope today was helpful, despite the fact that I dropped right off and thought about not coming back, I might add. This slide provides contact information for the coordinating office. Also, reach out to your PRCs or your RN team leads that are supporting long-term care in your subregion. Worst case scenario, give me an email and I'll get you in the right direction. Again, a sincere thank you.
Thank you so much, Allison. I'm personally very glad that you came back onto the call because I was trying to get caught up to speed. And thank you so much for the talk. There was lots of great discussion in the chat box throughout, but we do have a few questions I want to quickly get to so that we address them.
Sure.
Number one, we had somebody asking around if this tool might be used with clients with developmental disabilities for behavior tracking.
So yes, so of course, the tool has been standardized for dementia observation system. However, it's looking at trends and behaviors, right? It's looking at possibly contributing factors. And so I think it could be used with anybody. We all have behaviors. And so I think, yes, absolutely. And it's looking at being really clear and being very objective about when the behaviors are occurring, really honing in on that context as well, like what might be going on around as well. So.
Yeah, and Carrie's following up was curious if adults with developmental disabilities were part of the standardized sample. I don't know that we can speak to that.
No.
But Behavior Supports Ontario may be able to, and they do have a contact email on their website as well. Other question we have? Sorry, Allison.
I'm just going to say there's a user guide and there's a commonly asked questions, Carrie. So I wonder if that might be a great place to go on the Brain Exchange website.
Thanks, Allison. If somebody is on DOS tracking, should there be point-click care documentation to help back up the personal expressions that the team is seeing as well? That's the next.
So I think documentation is knowledge and knowledge is power, right? So certainly I feel like point-click care or any kind of progress note that can maybe give you a clearer picture of what was going on, what exactly objectively, what was the behavior, and also maybe what some strategies were that, so that it demonstrates sort of looking into the behavior a little bit more, right? Yeah.
All right. And
I think it's a great idea.
I agree. I think the more documentation, objective to support what you're seeing in the DOS makes a lot of sense for sure. Final question, and I don't know that we can answer this one either, around that fillable online version of a BSO version 2. So is there
So
or will
it
there
is
be?
there. It's coming. But it is something they specifically want you to reach out to their coordinating office about.
Wonderful. So thank you again, Allison, and thanks for all the questions from the chat.
Yes, thanks everybody.
Next month for our practice short, we have our NSM SGS pharmacists, Sandra Zakos and Beverly Ann Oliver, and they'll be speaking to us about a delicate balance, medications and falls risks in older adults. So again, you can register for that now, and that will be October the 10th at 8:30. And we heard from Edward that he misses seeing our faces. So if any of you also would like to see our faces live and in person, we'll be, throughout North Simcoe, Muskoka in October and November. We've got a number of things coming up. PAC, Positive Approach to Care in Muskoka and North Simcoe in October, as well as GPA in Barrie. So you can register at nsmsgs.ca/education. Brittany's put in a resource page, and that basically is our time for today. Thank you all for coming, and we look forward to seeing you in October.
Bye, everybody.
Have a great day. Bye.